guys got this. Is that famous last words kind of thing, right? Right, so just kind of keep in mind, right, as we go through all these disease processes and everything too, the key here is clinically, right, real world, high index of suspicion. Right? You're never gonna make the diagnosis that you didn't think about. It's easy to miss a lot of these things. Right? Are you gonna do the due diligence and, hey, I got that abnormal lab result, I'm gonna follow that, I'm gonna chase that. You're gonna ignore it and leave it, the next guy will catch it. Right? That when a patient comes to you with a complaint, night sweats, fever, chills, you just have the flu. Right? Again, it's high index of suspicion. And it's okay if early on in your practice you chase a couple zebras, right? I chased plenty of zebras early on coming out of here, right? Every patient I saw had a pheochromocytoma in my mind for a while, right? I swear, oh, she's got high blood pressure, so it's a pheo. Let's get some epinephrines on it, right? I chased it, like, you know, in one day I was actually gonna diagnose and find one. Never found one, right? But that's okay. I'd rather you chase a couple zebras and catch the bad stuff than not, and you miss the bad stuff, right? So just kind of think of that. And anybody diagnosed themselves with cancer since we started this? Usually there's a couple, right? Yeah. Feeling feverish, having a little bit of chills. I noticed a little weight loss all of a sudden, right? I got cancer, right? Everybody does that every once in a while. All right, so we're gonna hit the lymphomas today, and then we're gonna call it a day. Anybody here into sports? Any sports nuts? I'm a kind of a sports nut, all right, the Olympics. What do you got there? Olympics, 1936. There is Dora crushing everybody's hopes and dreams, breaking the Olympic records, right? Dora, as it turns out, was a dude. Okay. So the Germans, like, hey, you gotta prove a point, we're better than everybody else. So Dora, or dude here, whatever his name was, lived as a female for like 3 years and was killing everybody in the Olympics. So when something doesn't look right, there's a reason, don't ignore it. Right? That's the lesson here for you guys. Be suspicious. Right? And that's the thing with cancer. You gotta be suspicious, right? Because if you just, there's a reason for whatever that complaint is, right? You're gonna miss some stuff. Be suspicious. All right. Good times, lymphomas, fairly straightforward. Hodgkin's, non-Hodgkin's. Why does this thing hate me so much? Oh, I know why. Everybody knew what I was doing. All right. So lymphomas, kind of extension from what we covered yesterday, right? So B cell, T cells. There you go. The first group of cancers originated in the lymphatic system. Lymph, all right. What's oma? You see oma? Mass or a tumor? All right. Malignant transformation, B cells, T cells, natural killer cells. Affect the lymph nodes and other lymphatic tissue. Classified, two main types, Hodgkin's and non-Hodgkin's. Hodgkin's, presence of Reed-Sternberg cells. That is like pants written all over it, right? So if you see Reed-Sternberg, you know you're dealing with a Hodgkin's lymphoma. Now, are you going to see those? Are you the person seeing those? Where is that coming from when we say? It's seen on biopsy, right? Because when you do a biopsy, it's going to come back with Reed-Sternberg cells. Non-Hodgkin's, no Reed-Sternberg cells. Got it. Non-Hodgkin's, much more common. And So Hodgkin's, we'll talk about this a little bit. This is significant, right? That bimodal distribution. In general, when you're talking about a non-Hodgkin's, your risk increases as you get older, like we talked about a lot of these cancers, right? As you get older, you see that distribution. This is one of those, in the case of Hodgkin's, that has that bimodal distribution. Early on, age 15 to 35, high, and then again over age 55. So this age distribution, think of your population that you're seeing. If you're seeing a bunch of active duty, age 15 to 35, right? Our last deployment to Africa, sort of Africa, I ended up in DJ, here and there, halfway between, right? I ended up 2 patients in a very short period of time with Hodgkin's. 2 active duty army dudes, right? Stopped into my clinic, right, on my way from Yemen, my corpsman brought this dude into me, huge mass on his neck. Right? Ended up being Hodgkin's. A couple weeks later, I had another one. It was like, what the hell's going on, right? So you'll see that, and that's the age population, right? 15 to 35. Think of your active duty force. Somewhere in your career, don't be surprised if you run across this one. All right, classification. World Health Classification, sure, got it. And this is what we're talking about. You guys know this by now, right? So there's your lymphoid cell line, lymphoblast. At the end of the day, B cells, T cells, natural killer cells. What's a plasma cell? Differentiated B cell. And what's the job of the B cell? Antibodies, right? So your plasma cells are the ones that's producing antibodies. All right, so non-Hodgkin's, we said, no Reed-Sternberg cells. Non-Hodgkin's can be B cell or T cell. It is predominantly B cell. About 70%, 70 to 80% are going to be B cell. All right, there you go. Non-Hodgkin's, malignant lymphoid neoplasms. B cells or T cells, aggressive. B cells tend to be very aggressive. Incidence, can occur at any age, yep, got it. And then at the bottom is, we'll talk about some of these specifically. The diffuse large B cell we'll talk about MALT, and we'll talk about Burkitt's. All right, so really worry about all of that? No, don't worry about the translocations. I'm not asking you guys about translocations and what genes, right? This is not a genetics course. But I will say immunosuppression and chronic inflammation, right, plays a role. I will talk, when we talk about MALT, we'll talk about the relationship with H. pylori. HIV, we don't see too many HIV positive patients, right? But HIV patients, if you're out there working in the civilian sector or wherever you're working, a lot of times, big complication with them, they develop non-Hodgkin's. Other things to consider. Do they have some chronic inflammatory disease? Sjogren's is known for this, rheumatoid arthritis. And then chronic infections, H. pylori. What's EBV? Epstein-Barr. And what this disease we see often, what disease process from Epstein-Barr that we see? Mono, right? So patient had a history of mono, right? Don't be surprised. And then chemical exposures, pesticides, hair dyes, all these ladies who continue to dye your hair with super toxic stuff and kill some brain cells and everything else along the way. Non-Hodgkin's, indolent. When we say indolent, what are we talking about? Slow growing, right? Slow growing, painless lymphadenopathy. B symptoms. I think we talked about B symptoms yesterday, right? Fevers, night sweats, weight loss. So they're the classic things we think about when we think about cancers. Aggressive type, rapidly enlarging. B symptoms present most of the time, well, 50% of the time, right? in the aggressive cases, and then extranodal involvement. And you'll see where that differs when we talk about Hodgkin's. So these are aggressive, and they can spread to anywhere, really any organ system. Symptoms of tumor lysis, I keep promising you we're going to talk about tumor lysis, and we'll talk about some of the oncologic emergencies, but for now just think of it as, hey, you treated a disorder, the cells lyse, and because you have so many cancer cells in your system, these cells release everything that they have in them into circulation, and that causes a lot of problems. For instance, these cells are filled with potassium. You lyse all these cells and now just release all this potassium into your system. What could go wrong? Arrhythmias, anything, right? This high potassium. I release all this uric acid in the system. What could go wrong, right? So, and we'll talk about that disorder specifically. Physical exam findings, yes, lymphadenopathy. Non-contiguous, or you'll see some textbooks refer to it as non-contagious, all right? And we'll talk about what that means exactly. And yeah, sure, hepatomegaly, splenomegaly. Non-Hodgkin's, indolent phase, aggressive, two different types. So, hey, this one, going back, non-Hodgkin's, non-contiguous, or non-contagious. Just meaning, when they spread from lymph node to lymph node, they can jump around, right? So for those that are, when you see Hodgkin's, we're gonna talk about being contagious or contiguous. So typically in that case, a lymph node that starts here would spread to one of these next to it. If you get one here, and oh crap, I got one down here, that's non-contiguous. Everybody tracking? I see some head nods. I don't have a lot of confidence right now.
Sir, we're missing a couple slides.
You're making that up. I'm pretty sure you're making that. Which one you guys are making?
This one.
Oh, that's okay. You have it later on. It's gonna come. It's gonna come.
We don't have the non-contiguous on the previous slide.
What? No, that's going too far. Wait. This, like this, you guys don't have?
Just
the thing is just non-contiguous.
Okay.
We have the rest of it.
You got it. Alright. If you see a lot of stuff going sideways, yo. Alright. Non-Hodgkin's lymphoma. Workup. This is the key, right? How are you gonna diagnose this? You suspect it, yada yada, sure, now I need to make a diagnosis. Excisional lymph biopsy. Okay. You need to get a biopsy so you can take a look inside that cell. And that's how you make the diagnosis. And yeah, they do all this immunochemistry and phenotyping, you got it, right? Ultimately, test is an excisional biopsy. Additional workup, sure, I'm gonna get my CBC, right? You see these patients, you're gonna get a CBC. What do you expect to find? Probably anemia, probably some thrombocytopenia. Peripheral smear, right? We're dealing with a problem of what cell line? Lymphocytes, right? So you expect to see some lymphocytosis. And then you get your chem panel. LDH, uric acid, calcium, and we'll talk about that too when we talk about tumor lysis. But why elevated LDH? Why elevated uric acid? Yeah. So cell destruction to some extent, right? Alright, so uric acid we talked about before, right? And then LDH, so where do we find LDH normally? Yeah, a lot of places like liver, right? It used to be part of the cardiac panel and all kinds of stuff. But the other thing with LDH, cancer cells have more LDH than normal cells. So in the presence of all these added cancer cells, it's not uncommon to have an elevated LDH. But is it specific for anything? No, right? But yeah, expect to see that in these patients. And then a PET scan for staging and see, hey, where did this thing spread to? Right. Treatment, chemo. And CAR therapy, we'll talk about a little bit, but CAR therapy is this chimeric, they basically take your T cells and they figure out a way to use your own T cells to target cancer cells. It's pretty cool, actually. And then radiation in some cases, and hematopoietic stem cell transplant. Key for treatment, typically, this is where you start with chemo. All right, not treatment, so indolent. What does that say? Observation. Don't treat it with glucocorticoid steroids. Too soon? My bad. Couldn't help myself. All right, so again, indolent, right? These are the non-aggressive. Sometimes it's okay to do nothing and watch. Opposed to the aggressive, right? These days hit with this chemo, that R-CHOP is sort of the where people start these days. Need you guys to remember every one of these drugs and be able to spell them correctly. Absolutely not, right? Just kind of in the back of your mind, hey, what's the treatment typically for aggressive? Aggressive is aggressive, so we get aggressive and we hit it with chemo. Okay. CNS prophylaxis. Why CNS prophylaxis? Who remembers yesterday's lecture?
Once it gets in there, it's like free.
Yeah, it gets in the CNS system, right? Does it stay there and then reoccur even though you think you hit it and you didn't target it and treat it? So you want to make sure. Relapse, yep, more advanced treatment, more advanced therapy. Again, primary care PAs, right? We're not going to be knee deep into this. We are not going to start somebody on R-CHOP. Right? Should you know in the back of your mind how you treat this in general? Hey, you know what? This is an aggressive disorder. We go aggressive, we hit it with chemo. All right. I know you guys don't have this slide because I just threw it in like last night when I couldn't sleep and I was thinking about you guys. Yes, that's why I couldn't sleep, because you guys. All right. R-CHOP, right? So again, this is the idea that none of the treatments we do, nothing is benign. And cancer sucks and the treatment sucks. Right, that R-CHOP we talked about, this is just like the beginning, like couple whatever of the side effects. Like that goes on much, much more. So your patient, right, they're miserable. So have a little empathy for your cancer patients. Because, again, no treatment is benign. All right, non-Hodgkin's prognosis, indolent, right, the non-aggressive. Yeah, long survival, often curable, aggressive, potentially curable, but 5-year survival there, not so bad now. Indolent versus aggressive. Any questions on the non-Hodgkin's? B cell, T cells, right? Do they have Reed-Sternberg cells in non-Hodgkin's?
Sir, is that pattern of the more aggressive the cancer, the more potentially curable it is, that stay with other cancers, or is that really just lymphoma, non-Hodgkin lymphoma thing?
So the more aggressive, the more potentially curable?
Yeah, because like this slide says that the aggressive version is potentially curable, and the non-aggressive version is not, but you'll live longer with it.
Yeah, so I guess it depends on, yeah, I guess, sure. And I guess I'd have to think about that with other cancers too, right? So not curable, but they're often gonna survive and live forever. Like the same thing with those CLL patients we talked about yesterday, right? It's this indolent, slow process. So is there a real rush to find a cure if I can manage and keep the patients going, right? And there's a lot of stuff on cancer. And I don't want to feed into any of the conspiracy stuff over the years on cancer. We've found a lot of drugs that are able to target and manage cancer, and then there's a lot of cancers that people say, man, how come we can't cure this one, but we can cure this one? And then somebody will say, well, the money that these industries make from cancer treatments right? So are they really incentive to find a cure, right? When you can continue to charge people, because these treatments aren't cheap. Right? And if I have a disease process that the patient can live a nice healthy life without going for it, as a drug company, am I gonna invest a lot of money finding a cure when I'm gonna spend a lot more money targeting this one that's gonna kill them? Right? So there's a lot of stuff that comes into play with that, but I wouldn't say that there's necessarily more curable, they're more aggressive they are. All right, going on to non-Hodgkin's again, right? So we mentioned under non-Hodgkin's, you have some that are highly aggressive, and then we have indolent. Burkitt's lymphoma, highly aggressive. Yep, sure. And the three subtypes, endemic, sporadic, and immunodeficiency. We'll talk about these in a second. So this is a rapidly growing, this is highly aggressive, affecting B cells. Burkitt's lymphoma, Burkitt's, B, all right, aggressive. All right, clinical presentation, the endemic. And we'll have a picture, I think, in one of these, if not, I failed you. Right? Because once you see it, you don't forget it. Affects the jaw, facial swelling. You see this in children. So, do we, like, where's this seen at? Africa, right? We, military people, sometimes end up places where we don't want to be, or even where we want to be. So we don't think of this as something that you'll see in the United States, but that doesn't mean on some humanitarian mission or wherever that you don't run across it. And then the sporadic, we'll talk about with the abdominal mass, symptoms, pain, bowel obstruction, right? And then immunodeficient type. Lymphadenopathy, B symptoms. Right, there's your picture of your endemic. Most common, pediatric cancer, sub-Saharan Africa. See the peak incidence there, ages 4 to 7, mandible maxilla. Associated with what virus? ABV. All right. There's a sporadic, associated with that huge abdomen, right? They get the ascites, the fluid, the obstruction, everything builds up. Pain, sure. Bowel obstruction, yes. Nausea, vomiting. Not cool. Endemic, we said, yep, and immunodeficient, we talked about these symptoms, good. All right. Patient's labs, so again, back to imaging. CT, MRI, just to kind of figure out where this is, and then PET scans, are they lighting up over the place as it spread to everywhere? Pathology, right? Any of these is going to be biopsy. Don't worry about immunochemistry markers, and then the blood tests. Good treatment. Again, this is a non-Hodgkin's lymphoma. It's aggressive. We go aggressive. We go chemo. And that's just a series of bunch of a different regimen of chemotherapeutic drugs. Here again, intrathecal chemo for CNS prophylaxis. Right? They just get into the CNS system. And CAR therapy we talked about. But in our minds, just think aggressive, we go chemo. Prognosis, highly curable. 5-year survival, greater than 90, not so bad. Sure, requires hospitalization, yeah. And complications, good. So that's your Burkitt's in general, right? All right. We're gonna talk about something called MALT, mucosa-associated lymphoid tissue lymphoma. Again, another non-Hodgkin's, except this one is low grade. This is an indolent version. Key for this one is it's associated with H. pylori. What's H. pylori? Stomach. H. pylori? What's H. pylori associated with? Yeah, like ulcers, right? Gastric or whatever. Right. H. pylori. Could be associated with autoimmune. You see this with the Hashimoto's guys. Frequently extranodal. So again, this is the one that can kind of go anywhere, right? It's a non-Hodgkin's. Gastric mold, there's some lesions there, non-gastric mold. Can barely make that out. Non-Hodgkin's. Often asymptomatic. And this one, again, associated with H. pylori, associated with the gastric mucosa, you expect to see GI symptoms, right? So what do you get? Dyspepsia, epigastric pain. Rarely, some GI bleeding. But again, extranodal involvement is common. And just gone outside the nodes. Testing, endoscopy, sure, I want to go take a look at that GI mucosa. Alright. Histology, PET scan staging. Good. What's the takeaway from malt? H. pylori, right? There's gastric involvement, right? This is extranodal. Treatment. Again, going back to if I treat the underlying problem, maybe I took care of the problem. In this case, we said it's associated with what? H. pylori. So I'm going to target the H. pylori and see if that takes care of stuff. If that doesn't do it, then we go on to something heavier, right? Chemo radiation. Everybody tracking so far? I'm not even gonna turn around because I know everybody's doing a head nod. Not even gonna look. All right, prognosis, right? So again, when you have some etiology that you can target, in this case H. pylori, if we successfully treat the H. pylori and it goes away, we're good. Disposition, outpatient management. Got it. Long-term monitoring for reoccurrence. So that's something too, right? We kind of, I don't know if we really talk about that a lot yet. But just thinking about any of these patients with any kind of cancer, right? What's the likelihood of reoccurrence? Right? So that's what your cancer patients live with, right? Once they, hey, we've treated them, they're doing better, they cure, the fear in their back of their mind always is, did the cancer come back? Right? They live with that. So when you see your patients who you know had cancer, if they come to you with some symptoms, right, you have to have a low threshold for go looking for that cancer again. Right? So did that cancer come back? And that should be on your mind too when you see these patients. Lugano classification, right? How do we stage these things? You see this is a version of Ann Arbor system, which is a typical way of staging cancer. So if anybody ever asks you about Ann Arbor staging, how do you stage cancer? We're going to talk about specifically about the Lugano classification. Here's your Lugano classification. So hey, where's affected? If it's a stage 1, have one node, right? Single node. Stage 2, 2 or more nodes on the same side of the diaphragm. 3 nodes where? Both sides of the diaphragm, and then 4 spread. Right? Additional non-contiguous extralymphatic involvement. I would be familiar with the Lugano classification. All right. Hey, here's some. This is an international prognostic index, and the key to this is, hey, how do we kind of figure out who's at more risk than others? Who do I need to be more aggressive with when it comes to treatment? Low risk, 0 factors. High risk, 4 or more. So it kind of helps me figure stuff out. And just stuff you can think about. So again, any of these cancers, as you get older, your risk increases. So age greater than 60. I run the lab, my elevated LDH tell me something's bad. The stage 3 or 4, you have more involvement. It's gone extra nodal, sure. Right? Poor performance status. I think I put a slide in there on that one too. Yeah, so this is awesome, right? So we'll take a quick look at this. So this Eastern Cooperative Oncology Group, and you got a million of these different societies out there, right? So this is the part of their calculation for all that stuff, and it goes from 0 to 5. 0, patient is fully active. 5, your patient's dead. All right, game over. So somebody talked to you about a patient in category 5. Yeah, not good. All right. No, you don't need to know this, right? Don't try memorizing like who fits into what category. Not necessary. PET scans. Right? So PET scan is important for staging. What does a PET scan tell you? Metabolic activity. So you can kind of see what's lighting up, right? The top is the one before therapy. Look at the nodal involvement spread, right? Different organ systems, right? Next to it is after therapy. That's a huge difference. Before therapy, they got all this going on. Not good. Much better, right? And that's kind of what the PET scan. All right, there's PET scan, pre-chemo, post-chemo, lighting up again. So chemo works. All right, non-Hodgkin's, suspect, right? Kind of what we started. You have to have a high index of suspicion. It's easy to miss some of these things. As always, we're gonna do what we do. We're gonna get some labs. Here, go get a CBC, get some chem panel, right? You see this patient trying to help us figure out what's going on. And then if they have nodes, right, like palpable, these lymph nodes, ultimately you need to get a biopsy. So that's what's gonna make your diagnosis for you. This other stuff will come. This is our job here, right? Suspect it, get some labs, maybe get a biopsy going, and then you're like, oh crap, right? Now you're gonna do what? You're gonna refer that patient. Non-Hodgkin's lymphoma. B cells, T cell lymphoma, vast majority are B cell lymphomas, and then you have aggressive versus the indolent. All right, Hodgkin's. Hodgkin's lymphoma, Reed-Sternberg cells, yes. B cells. I don't see T cells on there, I see B cells. All right. Malignancy of B cells, there we go. The world famous Reed-Sternberg cells. People show you like a picture of like an owl. If you see the cells look like owl eyes or something. Bimodal distribution. Heavy association with Epstein-Barr. So they come in a couple of different flavors. For us, we're going to concentrate on the classical. Right? 90% of the cases are classic. So for us, everything is classic. Just know in your back of your mind, you have this other rare type, that nodular lymphocytic type. All right, there's your classic. Your classic comes in a bunch of different flavors. All right. Nodular sclerosis would be one of the more common ones. All right, painless lymphadenopathy. Painless lymphadenopathy, often cervical, could be mediastinal. And these tend to rise, single lymph node, spreads how? Contiguous. How did non-Hodgkin spread? Contiguous, right? Again, these symptoms, fever, sweats, weight loss, right? Night sweats, fever, chills, weight loss. Pruritus and alcohol-induced lymph node pain. They drink alcohol and it hurts. So or, you know, you're getting your history with this patient, it's like, man, I was drinking last night and this lymph node, this thing started hurting me. Like, that's a red flag in your mind. Alcohol-induced pain, Hodgkin's lymphoma. Physical findings, yep, firm rubbery lymph node, got it. So the other thing on here, so mediastinal, yeah, so these are things too sometimes, right? Again, that bimodal distribution, 15 to 35, sort of that active duty population. And you go send a guy for a routine chest x-ray because he's getting a dive physical, or he's getting a flight physical. And you come back with an x-ray finding like that, and you're like, oh crap, now what? Sometimes it's identified, just kind of incidental finding. Likely asymptomatic. Cough, shortness of breath. And again, this one spreads how? Contiguous, non-contiguous? Contiguous. So go back to this a second. So sometimes with these patients, right, they can end up having a lymph node sitting on a structure in here, like their trachea, and causing some airway obstruction, and they could present like that. Right? Sometimes they could end up with a supravena cava syndrome. You guys know what that is? Yeah. Right. So again, a mass sitting there on the superior vena cava causing issues. We'll talk about that too. That's it. Go. Etiology less clear. Hey, this one. So this familial relationship. So if you're seeing a patient, and again, because you guys are all great PAs and you got time on your hands and you're getting a good history from a patient, right? That family history matters. Oh yeah, my so-and-so, well, my brother, my sister had Hodgkin's. Right? And they're in there telling you about their weight loss, fever, and chills. 10 times greater chance, right? And again, we mentioned the EBV and HIV and autoimmune stuff, right? Any of these in these suppressed states increased risk. Diagnostic workup. You need a what? You need a biopsy. You need a fine needle aspirate. I'm just, getting this node is too difficult. Let's just stick a needle in there and take a look and see if we're good. Does that answer your question? No. You need an excisional biopsy. All right, I told you, my conscience is clean. All right. Don't worry about the immunochemistries. All right. And then the usual additional stuff, right? We're gonna get a CBC. You're gonna get your chem panel. Right. Stage in Ann Arbor, right? Lugano classification is what we're talking about. There it is. So Reed-Sternberg cells, your allies. All right. Those are your Reed-Sternberg cells. Treatment. What's our treatment? Chemo. Right? If you're super studly and future oncologist and you want to memorize those drugs, go for it. Right? Chemo with some radiation. Relapse, you can see. Prognosis, not so bad. And so in your minds, you need to be able to differentiate a Hodgkin's versus a non-Hodgkin's. How does it present? How does it spread? What's the etiologies behind it? More of the same kind of IPS risk factors. You do your calculations. You can memorize all of that. I think I can write at least 6 test questions off of this slide. Maybe 7. All right. Staging, yeah, PET scan, and then Lugano we talked about. Good. There's your Lugano again. Good. Key for Lugano, right? Where is it in relation to the diaphragm? How many nodes involvement? And there's a nice picture of kind of the Lugano. Stage 1, you just got one set about the diaphragm, in this case, on one side of the diaphragm, 2 on one side of the diaphragm, either side of the diaphragm, and this is spread beyond. All right, lymphomas. You guys got all of this. I see some looks of like, yes, this is too easy. All right. B cell, T cells, Hodgkin's versus non-Hodgkin's. Which one has the extranodal involvement? Non-Hodgkin's. Moth. Where's moth? So, right? H. pylori. Okay, all right, make that association. All right. Again, this is a little bit helpful maybe, depending on how you study and learn stuff, right? So non-Hodgkin's, B cells, T cells, natural killer potentially, right? Hodgkin's is just B cells, one spreads contiguous, one doesn't. Yeah. So huge differential for painless lymphadenopathy, and you're gonna see this, right? People are gonna come in, oh, my lymph nodes inflamed. Like, I got this thing on my neck, I got this thing in my groin, and you gotta go figure out why. So, painless lymphadenopathy, I get a little bit more concerned about than painful lymphadenopathy. When you get painful lymphadenopathy, what's your big differential? Infection, right? It's pain, right? You're probably associated with some infectious process. You get this painless lymphadenopathy. And if you saw, it talks about these symptoms that wax and wane, right? So the patient is having some lymphadenopathy someplace, and they make an appointment to see their primary care. And the stellar system we have said, hey, 3 months from now, come, you get an appointment with your primary care, and they come to see you, and the lymphadenopathy isn't there anymore. And you're like, okay, just continue to watch it. If it comes back, come see me, right? And then, 2 weeks later, it flares up again. So be mindful of those kind of patients. Be mindful of that story. Painless lymphadenopathy can be bad. Can also be a bunch of other crap too, though. Right? And that's what I say. Sometimes we sort of chase ourselves, but you always want to make sure that nothing bad's going on. Like I had a kid one time had some lymphadenopathy in his groin, and couldn't find a source, doing everything. Finally, I had to take his boot off, right? And in between his toes, he had this huge cut, right, that had gotten infected, right? And that has caused that lymphadenopathy in his groin. So sometimes you gotta go looking, right? You need to convince yourself and figure it out. And who's medical? Who sees patients? All right. So patients lie, believe it or not, trust no one, right? And this is gonna happen to you at least one time during your training, right? So you're gonna go and you're gonna see a patient, get a history, do everything you do, go back to your preceptor and you're gonna say, yeah, this is what the patient told me, right? And then the preceptor's gonna walk in the room and the patient's gonna tell you the exact opposite. I guarantee it. And you're gonna be like cringing there, like wanting to choke out this patient. But it's gonna happen to you, man. I remember I was at HM1 on the ship seeing this dude, right? Came in for this pain over here, and I'm doing my exam, and hurts a little when I push on him, but nothing. Going through full history. Hey, did you fall? Did you get hit? Did you get hurt? Everything in the book. No. Doesn't know why it hurts when he breathes. I get my doc in there to take a look at him. As soon as my doc walks in the door, he's like, oh yeah, I was playing football and I got tackled. I'm like, dude, I not asked you that question 6 times, right? And I'm looking like a whatever because I couldn't figure out that this dude's chest hurt because he got tackled. It's gonna happen to you. Just wait. And you're gonna get angry. But it's all part of the package. All right, non-Hodgkin's. In summary, we said indolent versus aggressive treatment. What's our treatment for aggressive? What's our treatment for non-aggressive? Observation. Reed-Sternberg, sure, chemo, yup, lymph node biopsy, all of the above. Alright. Does this do anything when I write on this board? Does anything make any sense to anybody? Oh, it's good for these dudes? Alright, so we don't. So I expect this group to get all A's on this test. And you guys out there might be out of luck. Alright. In that case, I was gonna.
10% curve for this one.
What's that?
10% curve for this one.
Alright, hey, so again, just going over lymphomas real quick. Alright, Hodgkin's versus non-Hodgkin's. Hodgkin's has what cell? Reed-Sternberg cell. Non-Hodgkin's, no Reed-Sternberg, come in two flavors. Well, what cell line is affected with non-Hodgkin's? B and T cells. Alright, under the B cell, you can think of aggressive and non-aggressive. Alright. Aggressive you're going to treat with, and non-aggressive you're going to? All right, malt, aggressive or non-aggressive? Burkett's? Good. Lectures. All right, I'm expecting all A's on this next test. All right, Olympics. Hey, everybody in this class was alive in 1988. Is that a true statement?
No.
I hate all of you. Really? 1990 what? No. Wait, we got a 2000, don't tell me that. 2000 and what? I got a special test for you next time. No way.
Still pediatric.
I started this program like in 2004. All right, so hey, Olympics, Seoul, 1988, ancient history for some of you guys, all right? 100-yard dash, this is Ben Johnson was running for Canada, Carl Lewis, US super stud. This dude was Christie from Great Britain. So they consider this has gone down in history as the quote-unquote the dirtiest race in history, right? So Ben Johnson thrashes everybody by 1,000,000 miles. Kind of looks like he might have been on steroids. He kind of was on steroids, right? So tested positive. Carl Lewis ended up testing positive for some banned stuff, and Christie tested positive for some banned stuff, right? So basically, everybody in this race. And if you could see the other picture, there's one dude who's like way back here somewhere, right? He was like the one clean dude in the whole race. Right? So when something doesn't look right, what are you guys gonna do about it? Do something, right? Don't ignore it. Because when things like this, like these anomalies happen, there's a reason for these anomalies. Don't ignore them. If you ignore them, you're gonna miss the bad stuff. Yeah. Steroids, steroids, steroids. All right, any questions about today's lecture? Somebody hit me with a question, not questions. Any questions about the leukemias? Any questions about myeloproliferative disorders? Do you guys even know what that is? Yes. Making that up. Polycythemia vera. RBCs. All right. CML. Philadelphia chromosome. Good association. All right. In that case, I'll see you guys next time.